Good morning, everyone, and welcome to this meeting of Adults and Community Wellbeing Scrutiny Committee. I am Councillor Hugo Marfleet, Chairman of the committee. Before we begin, the standard reminders: if we have a fire alarm, we need to leave the council chamber through the rear doors, into reception and assemble in the car park at the front of the building and wait further instructions. Unfortunately, Wendy Bokit she's got cold and sore throat and things, so I think she will be joining online. And I welcome Martin and his team here. So nice to see you all. And I'll introduce everyone else as we start and go through each item. Just a reminder to turn your microphones on when speaking and to turn them off when you're finished speaking. So on that note, we'll go to apologies for absence, please.
Thank you, Chairman. We have apologies from Councillor Nicola Clark, Councillor Lee, Councillor Overton and Councillor Carter, and we have Councillor Sear in attendance as a replacement for Councillor Carter.
Excellent. Thank you very much. Welcome, Noy. Nice to see you here. Thank you very much. Declarations of members' interest. Any member have any interest that arises, then please let me know. Go to the minutes of the 16th of October 2024. To confirm a correct record of the minutes of the meeting on the 16th of October 2024, the minutes are on page 5 to 13 of the agenda pack. Can I have a proposer for the minutes? Excellent. And that's Kellum. And seconded, Noy, thank you. Can I confirm that the minutes are all accurate and correct? Excellent. All in favour? Any abstentions? No, apart from me, because I wasn't here. And none against, that's fine. So all approved. Chairman's announcements. Just to remind you that there will be a drop-in demonstration of the latest care technology equipment today between midday and 3 o'clock in Committee Room 4. And it's always very nice to go there and see what the latest trends and what's happening and what's better ways that of communicating and helping everybody in their at home or wherever they are. But anyway, the latest technology will be on show, so that'll be good. Any announcements, Martin? Okay, right, thank you. So on that note, we'll go to the first agenda item, which is the Integrated Lifestyle Service. This report is set out on pages 15 to 91 of the agenda pack. Earlier this year, the committee considered a proposed decision on the contract extension, and at the time the committee recorded a number of comments which are relevant to the new contract. These were circulated to the committee on the 15th of November 2024. I would like to welcome Andy Fox, Consultant in Public Health, Carl Miller, Senior Strategic Commercial and Procurement Manager, and Sarah Mitchell, Contract Manager. If you would like to just give us a brief overview, and then we'll take it from there. Thank you.
Thank you, Chairman. I'll give you a brief overview of what the papers are setting out. So this pertains to Lincolnshire's Integrated Lifestyle Service, which is known as 1U Lincolnshire. And this is the service that we use for trying to help people to take control of their lives and make significant changes to the way they live their lives in order to improve one of 4 key risk areas in the population. And these risk areas are people who smoke tobacco, people who are at an unhealthy weight, people who are not as physically active as is healthy, and people who maybe drink too much alcohol, but importantly aren't eligible for our substance misuse services, which obviously we also commission. So this service is focused on 2 key forms of prevention. As we know, prevention is better than cure. The vast majority of health burden that means people end up in hospital beds and then ultimately maybe having increased pressures on adult social care can be attributed to cardiovascular disease, so heart disease, and dementias, diseases that often come on with older age but develop through our lives, musculoskeletal problems, and indeed important diseases such as lung cancer, which is still one of the single biggest contributors to some of the differences in life expectancy we see in the Lincolnshire population. So the two forms of prevention that we're really interested in here is primary prevention, and this is one of the few services in Lincolnshire actually which we can really say stops people from ever developing disease that they might otherwise would have done. If you can get people to stop smoking tobacco, their risk of developing lung cancer drops straight away. Accordingly, if you can keep people at a healthy weight, they're much less likely to develop type 2 diabetes, which is causing significant pressure across health and social care, as well as musculoskeletal problems which might limit their mobility, increasing the risk of falls, etc. So the primary prevention element of this is key because, as I say, one of the few services at Lincolnshire that actually stops people developing disease. Also secondary prevention, by which I mean we are people who are perhaps not as healthy as they could be. This service can step in and can help people to take control, make a change, and actually not develop further conditions or further complications that they would otherwise develop. That's also important because obviously we know we have a challenge in Lincolnshire, in fact nationally and internationally, with the amount of ill health in the population causing significant pressure on adult social care and on our health care systems as well. And this service will reduce demand on those services through those, those services are fundamentally more costly. And so quite apart from the fact that it does absolute good in the population through preventing disease, it also is a critical component of demand reduction in our services in Lincolnshire. So that's what the service does. What we're setting out today is a proposal to continue to provide that service in Lincolnshire. The current contract extension is running out summer next year, so end of June. And the service has been evaluated, and we have talked about this when we brought the recommissioning report, and has found to be working. In fact, it is outperforming national targets and benchmarks in each of those 4 key pathways, and essentially is become something of a Lincolnshire success story in that the provider who currently delivers the service, Thrive Tribe, have managed to take other contracts elsewhere in the country, largely on the strength of the excellent work they've developed and are doing in Lincolnshire. So we are sort of leading the way, and other people, Nottingham for example, have really adopted the model we use here because it's seen as being effective. So we are proposing to continue to deliver One Year Lincolnshire for an additional 3 years with 2 3-year extensions in the contract. We are proposing as part of this that 2 of the core, or the core element will be continued, funded from the Public Health Ring Fence Grant with a contribution from our NHS colleagues at the Integrated Care Board. And that will be uplifted via a small amount to account for inflation. Essentially, we're proposing to continue that core delivery, which buys 10,000 outcomes per year across those 4 pathway areas. So obviously there's a need to uplift that in order to be able to essentially get the same value as cost pressures have increased. We're also proposing to increase the investment via embedding 2 pilot areas, which we have developed over the last few years, which have been evaluated successfully. And this is the Child and Family Weight Management Programme, where we ensure children and young people who are measured at school, as happens every year, found to be overweight or obese, can actually access some fun, helpful support for the parents as well as them. The kids will do an activity, the parents will get some coaching and some support, and that has found to reduce the weight of a majority of children who have completed the course, which again is outperforming other schemes nationally. And also our falls prevention, strength and balance service, which is significantly oversubscribed, incredibly popular, and found to improve the the strength and balance. So the timed up and go is the metric they use for people who are struggling on their feet a little bit in the vast majority of participants, and is significantly going to be reducing the risk of falls in that cohort. So we are proposing to mainstream those two piloted elements as part of the core service and continue to deliver those for the lifetime of the current contract. And we have evaluated the cost effectiveness of the service, and we have found it to be extremely cost effective. This tends to be the case with services that actually do work in terms of that prevention argument. And what we've done is we've done a full academic cost effectiveness evaluation using the most stringent methods, which, you know, we could publish that academically if we wanted to. I actually have a national role on a NICE, the National Institute of Health and Care Excellence committee, where we evaluate these, and it's the same methodology we use for that committee. So it's incredibly robust and stringent, and we found that even just using a very limited set of sort of benefits that this service gets, it still generates a return on investment of over £4 for every pound invested. That will be a vast underestimate over the lifetime. We know that public health interventions in general are thought to deliver sort of 14 to 1 in terms of return on investment. If we only count what we can count here in Lincolnshire over a very short period of time, we still get over £4 back for every pound we invest. And we can also work out, and I'll just explain what this is, that the National Institute of Health and Care Excellence, NICE, have a way they can calculate what is a cost-effective healthcare intervention. The way they do that is they come up with a value for a single year lived in good health that they consider to be cost-effective for the NHS. And a single year, if you're interested, this is all in sort of the public domain. I'm not giving away any trade secrets here. The lower threshold that NICE use for that, for a single year lived in good health, that's called a quality adjusted life year, or QALY. You'll see that term used in the papers, is £20,000. So that's considered a good use of NHS resources. If we spend £20,000 on one person living a year in good health, and now, NICE will go higher than that, just to reassure you, for rare diseases, etc. This is for sort of population-level interventions. Our calculation of the cost per quality-adjusted life year for this service was 8 times lower than that threshold, 8 times better than that in terms of cost effectiveness. So if you want to look at it that way, you could say that we are 8 times more cost effective using this service than what NICE consider to be a good use of monies for the public sector. I'm really pleased with that result. It proves that this service is delivering benefit to the County Council and indeed to our NHS partners who also invest in it. So it's a cost-effective service. We're proposing to expand it, as I said. What we're also proposing is that if we do have further investment opportunities from different budgets, and discussions are underway now, through the before the start of the contract, we are asking for the ability to pilot an additional element of increasing the investment in the harder to reach groups, those core 20 groups that 10% and 20% most deprived of the population, who are far less likely to engage with preventative services and have far more likely to be in ill health. So there's a real need to focus on that population more. So we are proposing a method of doing so. Should funds become available, that will be an annex to the contract. Obviously, if funds do not become available, we will proceed with the core contract with the inflationary uplift and the piloted areas added in as set out in the papers, for a total value of 3.4 million. So that's what the service is, that's what it does, that's how cost effective it is. I will just hand over to Carl to talk you through the commercial and procurement implications.
Thank you, Andy. So taking account of the findings from the market and other engagement and review activities that have been completed, from a commercial perspective, it's proposed that, as Andy said, the new contract will be for an initial period of 3 years with a potential for 2 further 3-year extension periods up to a maximum of 9 years in total. That's intended to allow for the service either to be continued or concluded at the end of each of those periods, should funding either no longer be available or should any of the service elements not be meeting outcomes. That will also give us flexibility for the incorporation and or the removal of potential future pilot elements referenced by Andy, aligned to their associated funding cycles. Terms will be incorporated in the contract to enable the regular review, evaluation, development and performance management of the service, with appropriate options to terminate at certain intervals, or indeed to vary the scope of the services to maximise future flexibility for the council. The price will be set within the available budget, 3.415 million for the core services, and will be fixed for the initial term, with any inflationary adjustments on extension subject to agreement between the parties and at the council's discretion in consideration of the council's budget position at the relevant time. As the ILS services constitute community healthcare services, it's the healthcare services provide a selection regime, regulations that are the appropriate procurement rules governing this process, and an open competitive tender process is proposed as the most suitable route to select the future provider of these services. Given the commissioning intentions to maximise the delivery and the reach and the impact of the services for the available budget, tender evaluation criteria as part of this process will focus on maximising service quality and throughput volumes achievable within the available budget to ensure that the most effective and highest impact delivery is achieved for Lincolnshire's residents. From a performance management perspective, the focus will be on delivering continued improvement to people's health outcomes, with progress being sought in particular in the most deprived areas of the county. We'll also include an open book accounting approach within the terms of the contract to support monitoring of service delivery costs, and we'll have a gain share mechanism to ensure that the benefit of any efficiencies that are realised through the delivery of the services can either be returned to the council or reinvested in service provision as appropriate. Thank you, Chairman.
Excellent, thank you very much. Well, personally, I think the report is very well written. I think everything's been, you know, we've dived down, we've checked everything out, we've re-evaluated, and I think it's sort of what I call the exemplar to how commissioning, how we commission services and how we adapt over time and change, and that's been taken into account here. I suppose one of the questions I've got is that the fact that potentially the government has said that they want to go down this preventative route rather than treatment, if there does suddenly become more money and the NHS actually puts more money our way as well, are we geared up to sort of even evolve this into a sort of a wider spectrum, I suppose, or enhance it? Because I think, you know, personally, if they go down the prevention road, it is better, and it's quite clearly highlighted that in here when you look at the nice formulation costing around 20,000, and I think we're at about just under 2,000. So, you know, it really does highlight just how cost effective it is and what people need. So are we geared up to expand it and adapt it if that extra funding does come forward?
Thank you, Chairman. I would say yes. I mean, obviously, we don't know what's coming down the line at the moment. So it's important to have flexibility, but also set out where we think the next step would be in terms of expansion of this contract. That's what the papers in front of you sort of set out. We absolutely want to build on the success that we've already had. We have set out that annex, so if additional funding is available before the contract start date, which is obviously still be in the summer next year, there is some likelihood of that. We know what we want to do with it. We've done the work. We know where we want to put it. What I would say is, obviously, if additional money becomes available after that, there will be some flexibility in the contract terms, which Carl can give more information on, and there would always be the possibility of other contracts as well.
Thanks, Andy. Yeah, absolutely. So there will be flexibility built in. There are certain potential developments that are foreseeable at this point in time, and we will make express provision to include those in the contract in future should funding become available to support those initiatives. More generally, there will be flexibility to modify the contract as we move through it, subject to the level of change required. It might either be possible to incorporate within the scope of this contract, or it might be necessary to look at a separate discrete procurement exercise. We'll really need to take a view depending on the nature of the additional requirements at the relevant time.
Excellent, thank you. Martin?
Yeah. By the way, yeah. So I think it's worth noting that this conversation we're having very much fits in with the national picture. So members of the committee will be aware that the Secretary of State is talking about 3 shifts in the health and care system, about from treatment to prevention. Well, this absolutely fits in that area. From acute to community, well, this is something that is being done in the community, working with people who are still within their communities, in their own homes, so it absolutely fits with that. And a shift from analog to digital. So one of the things we're looking at is how can we make better use of technology to draw people into these services. And I think that also fits, as you said at the start of the meeting, Chairman, that there will be a demonstration of assistive technology. So there's a lot of work that we're doing which absolutely fits with the national trend, and therefore we are going in the right direction, and we're making sure in the contracts that we're putting in place that we are ready. You know, should there be funding made available? And of course, there are lots of noise being made nationally. ADPH is the professional body for directors of public health. ADAS is the professional body for directors of adult social services. We're all making as much noise as we can nationally to argue the case for local authorities having a central role in these shifts, because actually that's the way that the NHS can be effective and survive. But also, it's surely better for individuals to have a good quality life in their community without the need, without developing the conditions that mean that they need to go into the NHS. So, ultimately, this becomes about the people of Lincolnshire having the best possible quality of life, and us lining up to make that possible.
Excellent, thank you. And right, I've got Trevor and then Callum.
Yeah, thanks, Chairman. Excellent report. I fully support in terms of the recommendations. I just would like to understand in terms of the pathway more in terms of, for the customer. So in terms of my own ward, one of the most deprived wards in Lincolnshire, as a district council, we're doing a huge amount of work in terms of trying to deliver around health and well-being. I think this sits quite well within meeting a lot of the objectives around that, but still failing to understand. And we're also doing a lot of work with local GPs, trying to understand in terms of how we can benefit people's health and well-being through working more closely with local GPs. But I still fail to understand in terms of the pathway, because you're doing a fantastic amount of work. What I'm failing to understand is in terms of knowing how that delivers in my local area. I feel as though I'm well connected in terms of knowing how services work. I fail to understand in terms of, or I fail personally in terms of the lack of understanding in terms of how people refer into this service and how it works in terms of trying to deliver those benefits to those individuals.
Thank you, Chair. Thank you, Councillor. So the pathway is there are different ways to refer in, essentially, and absolutely you've identified GPs. So GPs can refer in. What I'd say is that when the contract first started back in 2019, it was envisaged that most of the referrals would probably come via GPs, via NHS health checks, which we also commission and provide through GPs. And obviously what happened in the interim was COVID happened. And basically, there was certainly that period in 2020 when nobody was going to their GP, essentially, for sort of normal issues, and people weren't seeing face-to-face. So the provider flexed and opened up to self-refer deliveries. So that's become a major referral route as well. And what they do now is they can go into areas and they can do some publicity, they can do some advertising, and they can gain self-referrals whilst also working through subcontractors, through pharmacies, through GPs to gain referrals through clinical pathways. We've also embedded this into NHS Lincolnshire's sort of musculoskeletal health pathway, so aches and pains, hips and knees, that kind of thing, so that anybody who is being seen by a clinician should be referred to One New Lincolnshire if there is a sort of a weight component or a physical activity component we can help with. And we have seen significant increase in engagement with the health sector, but also with self-referrals through the life of the contract. One particular innovation which I'd highlight, as the provider has been learning, I've been very impressed with the provider that we currently have. We will get at least as good a provider as that one going forward. That's the benefit of the competitive tender process. They recently discovered that GPs, through some work we were doing, weren't often contacting people directly who were on their register at being an unhealthy weight. So in partnership with the GP, this was in Birchwood, our One New team went in and they said, well, you've got everybody's number. Can we give you some text to send out on your text system and just invite people to a clinic? We'll put on a clinic. You've got, maybe 1,000 people on your register who we could do with seeing. We'll probably get 5 or 10 people. They put out this text message. The next day, they set up their clinic. 100 people turned up and were queuing out the door, really happy, and a brilliant atmosphere in the place. Turns out all we needed to do was ask via the right means. So there's been a big growth in the skill and the knowledge of the provider going forward, as well as embedding the referral route into clinical pathways. So it's a all rather than the single piece approach.
Excellent, thank you. Callum?
Thank you, Chairman. I've got just a few questions. So in terms of actually probably expanding on what you've just answered, actually. So in terms of how will the recommissioned service address any gaps identified in the current ILS model, particularly in engaging the most deprived communities?
Thank you, Councillor. Yeah, no, it's a fantastic question, because that's actually what a lot of the work we've done has been to focus on, because I'm very conscious that all the evidence says that essentially if you're going to just put a universal offer out to a population, you'll get the people in the middle or the people who are relatively well a lot easier than you'll get the people in the most deprived communities. What that translates into is inequalities in health. So the very preventative service that is going to help the sickest people the most, it's the people in best health that are using it more. And that's something that we need to build into our design of a service. So we have done that with the previous service. We instituted a target that 50% of the outcomes should come from the bottom 3 deciles, so the bottom 30% when it comes to that measure of socioeconomic deprivation. And the provider has finally slowly started to hit that, but in the evaluation that we've had previously, I'm pleased to say that even though it didn't hit the 50%, certainly when the university evaluated it formally, the bottom 30% deciles were overrepresented. So it wasn't 10% from that bottom 3 deciles, it was 38%, which basically means the service is having a positive effect on inequalities, but it could definitely do more. Now, we've identified that fundamentally, if you're going to do more, you need to be able to spend more time with people in these communities. You need to be able to offer something different. So this is what sits behind one of the proposed pilot, should funding become available, to spend an additional £900,000 on an additional 1,000 outcomes from those most deprived communities, which we'd be working with a provider. Now that even if that if funding doesn't become available, that's the work that we've done. We will work with the provider, as we've just described, who is getting better and better at targeting, and we are seeing a positive effect. Just to be clear that if we, if you're going to spend £100 on Lincolnshire, you want to spend 50 of it in the most deprived communities, and then the rest 50 in everybody else, because you'll get the right split of outcomes. You've got to put more investment into those communities. So the contract and the new approach will help us do that. But just to be clear, no one finds this easy, and actually Lincolnshire this is part of our success story in this. Lots of other services are like this in the country are probably increasing inequalities. Because they are just doing a one-size-fits-all approach. So we are learning as we go, and we'll get better.
So I think what you're also saying is, essentially, we can also have partnerships with other local organisations in terms of targeting and supporting different groups. I think one of the last things you just said as well, in terms of, so how will the service integrate with other local public health initiatives to avoid duplication and ensure comprehensive support?
Again, one of the other services we commission, for example, is NHS health checks. So this is the service that offers a health check to people sort of over the age of 45, and once every 5 years. And the ideal outcome from that health check would be, if they have need in any of these areas, they immediately get a referral to One Year Lincolnshire. So that is written into the way we're developing health checks. But almost more importantly, because I don't think health checks really are the answer to the population engagement with these kind of preventative services, we really need to build on the demand for these services. We've seen real success with the self-referral elements. We need to integrate it with the services that are meeting where people are. So this is about us essentially doing our jobs well and linking with partners in the voluntary and community sector, linking with partners of faith groups, etc. And some of the services that we in the County Council Commission, such as social prescribing services, which form the glue, if you like, to knit all those together. I think developing their understanding of One U Lincolnshire, ensuring that One U is an option that everybody is promoting, will be, I think, a priority for the new provider. So we'll work with the new provider essentially to, and it might be the same as the old provider, we'll see what we get, but to embed those approaches and to be as creative as possible.
Final question around funding, actually, and I think it relates back to what Councillor Young was saying earlier. So obviously there's a proposed budget increase to 3.415 million. Are we confident in securing sufficient funding for the extended scope of services? And are there risks of potential budget constraints impacting service delivery?
Very simply, I'm absolutely confident that we have funding secured for the 3.415 million. As I've said, there is less confidence around the additional 1.05 million for the annex enhanced delivery model. That is why that is being presented as an annex should funding become available. But we felt it was important, for the reasons that you've set out as a committee, to have our next plan in place. So we have done that. But yes, absolutely confident in the 3.415 million.
Excellent. Thank you very much. Mike?
Thank you, Chairman. It was a long read going through your report. I had to take it in stages. I found it very interesting. I must compliment everybody involved in it for providing all the necessary information. I fully support this preventative action that you're putting forward and proposing. I think it'll help a lot of people's health, and it will obviously reduce costs for future implications of ill health. Going to page 45 and 46, I was a little bit disappointed that unfortunately quite a few people have dropped out of their various activities to improve their health. What are you going to try to do to persuade those people to get back in the programme, as it were, or do you think they're a lost cause? Thank you.
I mean, it's again, thank you, Councillor. Really appreciate your support. But yeah, no, it is going to be a perennial challenge. That obviously we know that life is a challenge for many people. This kind of dropout rate is something that you do see in all of these interventions. Essentially, our interventions are probably doing better at this than the majority, and some of that is down to the way that we are pitching it. For example, the child weight management intervention we're using is deliberately designed to engage children and families with sort of a fun, non-stigmatizing approach that we're actually finding one of the challenges we have is we're getting people wanting to do it more than once. Despite having sort of achieved successful outcomes. So some of it is actually just working with the provider to make sure that the interventions we're offering are pitched right for the people of Lincolnshire. And so that is kind of local work and service development to just do it well, know what people actually want, know what people helps them. So the flexibility of the provider, I think, is key. And making sure we have a service specification in the contract which requires the provider to work with us appropriately to tailor the approach for different areas of Lincolnshire, for different populations, to be flexible. So we're not just looking for hitting the numbers overall, we're also looking for improving that quality. And that is a process. I'm very pleased our commercial colleagues are here. We have done through the life of the current contract. Obviously, we had the pandemic sort of intervening, but we have seen improvement in engagement all the way through, and I would like to think we'll carry that forward with any new provider we get. It is a challenge. It is something we'll continue to work on for the new contract. Basically, doing it well is the simple answer to how you can guard against people dropping out. Make sure you're not telling them you've just got to be healthy. Make sure you're doing them a genuine good, providing support and assistance. And then the challenge is that people come and bite your hand off, like they have with our falls prevention service, which is massively oversubscribed, for example. So.
Thank you for that. If I could ask a question about the contract. When I first saw 3 years as the option, because normally we do 5, but then when I read the information about the fact that you're aiming for the flexibility, that you can alter and change after the 3 years and subsequently another 3 years. And I found that very enlightening. That's a new approach. More flexibility in contracts, I think, is what is required. And certainly the data that you provide was very interesting to read. And certainly your comments there earlier on about trying to target the more unhealthy or those that are likely to be more unhealthy, I think that's a step in the right direction. Thank you.
Thanks. Couple of questions. In terms of, because the report sort of talks about the issue of trying to hit the lowest, the bottom 10% by in terms of deprivation. That's got me kind of thinking about targeting, and has been any sort of research done to kind of highlight those social groups that are more prone to smoke, drink excessively, potentially be overweight? So, because or does it tend to just sort of balance out over everybody within society? Because obviously, if there is that sort of empirical research that indicates that certain people, certain groups within society are more liable to be doing this in terms of the targeting, and appreciate the difficulty sometimes in reaching out to people. So that would be my first sort of question around that. And then in terms of some of the costs that you've worked out, how are you working out the value of the contract? Are you kind of just sort of taking all the staff that's involved and then putting on all of the non-pay costs, or are you working on a kind of which is kind of a top-down approach, or are you taking a more bottom-up approach, looking at the individual unit costs of doing things? Just be quite interesting just to understand that. Thank you.
Thank you very much. So I'll address the first question straight away. So what you're describing, unfortunately, these sort of lifestyle health risks, if you like, such as smoking, being an unhealthy weight, being physically inactive, they're not distributed equally in the population. We see the same thing in Lincolnshire that is seen nationally and indeed internationally, which is that actually for all of these, there are correlations with higher rates in different groups. But all of these can be quite effectively summarised by the fact that the correlation is strongest when you look at socioeconomic deprivation, which is a sort of a term we throw around a lot. It's a catch-all term. It basically includes measures of household income, education, but also the built environment around you, so green space and sort of access to transport and etc. So it's an overall metric which has been produced nationally for many years, which scores all of those elements, and then actually, if you're interested, ranks every lower level super output area, which is a census geography of around 1,000 people in the country, from 0 to, or from 1 to, I think it's like 12,000 or something. So you can look it up online and see where your LSSOA ranks. And if you group that into sort of groups in the population, you'll see that unfortunately all of the negative health effects are much more common in the lower socioeconomic groups, and we get what's called a health inequality. And if you plot that on a chart, this is actually the way we do it professionally, with sort of 10 groups is often what we use, so deciles 1 to 10, you see essentially a slope, and we call it the slope index of inequality. And you see that, and the simple way I do some, I don't want to get too academic, so stop me, but I do quite a bit of teaching, including medical students and doctors on this subject. And one thing I always do is I put up maps, and I say, this is a map of lung disease, this is a map of type 2 diabetes, this is a map of poorly controlled asthma, and I put them up, and all the maps look the same. So, yeah, it's a well-known, lots of research on that. The second question, I think, I'll turn to my commercial colleagues, but very simply, we commission for outcomes. So we're building on a contract value, and we go to the provider and we say, this is the value of the contract, this is what we want you to provide. It's up to you to achieve that in using the team structures and the number of staff as you see fit, and that allows the provider to be creative, flexible, and to be intelligent in the way they design actually what the services look and feel like on the ground.
Thanks, Andy. Yeah. So it's more of a top-down approach in terms of looking at the resources that are being invested in the delivery of the service to achieve the maximum number of outcomes required, or in excess of the minimum required. So we're really looking to the market to deliver as much as they can within the budget available. Obviously, we've developed an understanding of the resources that they put into and invest in the delivery of the services to achieve that through the reporting that they provide through the current service, and that will continue into the new service. So yeah, we are developing our understanding of fundamentally units, if you like, but that's not really how the pricing is derived.
Presumably within that, I guess that potentially there is a little bit of flexibility there, because your volumes over time might go up slightly, they might drop slightly, but over the term of the contract, those movements up and down can be managed by the provider. Because I'm just concerned at some point, if there's a huge increase in demand, or if we are successful in getting more and more people to come forward, it's just how much flexibility there is within those numbers. Thank you.
Yeah, thank you, Councillor. So what we do through our contract management approach with our provider is we would work very closely on looking at the demand numbers coming through. So we would be able to see trends across time, where there are fluctuations in demand, and we would be able to work with the service to understand, is this something that can be absorbed? How can we deliver this through creative delivery and areas like that. So we would keep a close eye on numbers coming in. Obviously, if they were dropping low, we would be able to work with the provider to understand why. Can we target sort of promotional activities? But otherwise, it would just be a sort of at least a monthly check-in with our provider to understand what the numbers are doing and how that can be delivered by the service.
Because I'm guessing from this, you want to actually get as many people as you can coming forward, because the report identifies all the benefits that are there in terms of this early intervention stuff. So the reality is you want to get as many people as you possibly can going forward. It's just at some point, and I hope we're successful in getting more people, in increasing the demand, having more people come through. I'm just wondering potentially a scenario where the provider comes back and says, we're now consistently 10 or 15 or 20 or whatever percentage above, where we've historically been. We have been successful. We are encouraging more people to come forward. Potentially, would they come back and look for increasing the contract value, or it's just because I see this as fantastic investment. Early intervention stuff is exactly what we should be doing. But maybe at some point, if we are victims, if we are really successful, would we potentially, how would we fund any, if they did come back and say, look, we are now consistently really above demand on this, and we are really struggling, and we've worked with them, we've looked at the figures under demand, and we can actually see, yes, we are consistently over. Is there anything in the contract that will allow us to come back and give them extra funding? Because it might be that we have to transfer that from somewhere else. But because obviously, for me, the key to all of this, across all of adults and children's social services, is in Lincolnshire, we have specialised in early intervention stuff for the last 10, 15 years, which we know is better for the people we're dealing with. It's better for the council. It's a win-win. Just if we do become too, well, not, I won't say no, because I don't think you can be too successful with this, but what would happen if consistently we were successful and that demand really did shoot up? Thank you.
So if we could see, if the provider was demonstrating that they'd maximise the capacity that they could achieve within the resources available, funded through the contract, then at that point there would need to be a conversation about whether there needed to be demand management methodologies put in place so that the service could continue within existing resources, and that might be looking at people waiting for access to services when those services became available, and or in the event that more funding were to be available, to adjust the payment mechanism to allow for the additional resources necessary to meet that higher level of demand.
Well, that sounds all good, and it's all sort of provisionally covered for the future. Just, a lot of these areas that we're trying to address, in some sense, what the people themselves often need is a buddy. Somebody that basically keeps them motivated when they're not in effect with One New Lincolnshire. Is there a mechanism or a way, looking at the sort of model that sort of the likes of One New Lincolnshire can actually sort of somehow connect the people? I mean, if, let's say, you've gone into your sort of a deprived area, you don't just have one person there, there'll be a few people there, and it would be good if they sort of could sort of bring them together or buddy them up to so that they all self-help each other through the programme. I mean, if you're going to, I've watched a lot of people talk about weight management, and the big thing that they all struggle with is the length of time that you have to keep going. It's all right, they can do it for a month, they do it for 2 months, but it's a sort of it's you have to keep the focus constant, and I think sometimes, you know, in all that I often hear, it's we need buddies, we need that extra person on your shoulder just to be there when you're about to break, and can they sort of bring that system into place somehow?
Yeah, thank you, Chairman. Yes, absolutely they can. And in fact, that's you're sort of describing the ethos behind the model of what we call Tier 2 or community weight management support services. So the first thing to say is that so the Integrated Lifestyle Service at present uses a health coaching model. So the idea is that whilst you're sort of officially receiving the intervention, there is a health coach who's there to provide some of that official support. But the idea being that exactly as you've set out, especially with Healthy Weight actually, that ideally that support is then provided in the community. So for adults, they're referred into often one of the sort of subcontracted Tier 2 weight management services like Weight Watchers or Slimming World, where that's the whole sort of ethos of that is you go into a group, you make friends, you meet people, you support each other on the journey. And that's where the best evidence is of effectiveness. And that's the same sort of model, but we're controlling it a little bit more. For the child and family weight management is we get a group of people together, they can laugh, they can chat, they can build friendships. And that's one of the real successes we've seen so far, has people saying, it's just been great to meet people in the same place that I am, and they provide that ongoing support. So that's absolutely the model, especially for weight management. It's interesting you mentioned that one, because that's very key, as you say, for the long-term follow-up.
Excellent, thank you. Right, well, first question is, do we support the paper? I need a proposer and a seconder. So proposed by Mark, seconded by Noy. All in favour? Excellent, everyone's in favour. Second part, comments to the executive. I can't really think of anything other than it's a great paper, and I think it's a great service, and actually it's gone to the market. It's consulted, it's identified the change, it's implemented the change in the agreement to be fit and more relevant for modern day, or today's rather than when it was initially concepted. So, yeah, very good news. So, thank you. Thank you all for coming. So, okay, on that we'll go on to the performance report. For this, I think we've got Caroline Jackson might be on Teams, and we've got Martin here and Justin anyway. I will let them just briefly go through, but it all looks like we're in very good shape. So,
okay,
we
thank
have
you.
got Caroline is there, I can see her.
So, thank you, Chair. Let's say we're having a little bit of adjustment of the IT, because Caroline is on the screen, but there's about 12 of her. Caroline is so good we have to have her multiple times. But just to sort of introduce this report. You'll note that this is a change from the way that we've done this previously. So previously you'd have had Caroline or a member of her team presenting the report. There are as always, lots of numbers in the report, and if I just note, the start of the report on page 93, 4 measures exceeded the target, 14 achieved their target. So that tells you a little bit, but I'm reminded of one of the things that one of the leaders in quality management some years ago said, that he said if you compare 2 numbers, the chances are that one will be different from the other, and that tells you that the numbers are different, but it doesn't give you that sense of why they're different. And so what we're now doing is having the service present the numbers, because partly, of course, this is our performance, and it is right that you should be holding us to account. So Caroline and her team do a fantastic job in pulling the numbers together, but it is clearly performance that is delivered by the service, and therefore it's appropriate that you should be holding us to account for it. It's also that because we are the service, we are in a better position to explain to you why we're getting the performance that we're getting. Caroline and her team can say what the performance is, but we can say the why. So overall, it's clear that we are delivering a good performance across most areas. We're meeting our targets. We are delivering good services for the people of Lincolnshire. We are achieving good outcomes for the people of Lincolnshire. That said, there is clearly still a lot to do. There are definitely issues in terms of the quality of our data. We're looking at aspects of our processes where it's become clear that we haven't been collecting and collating the data as promptly and as efficiently as we would have wished to, and that therefore there are aspects about the systems that we've been using, and therefore there is attention that is required in terms of our performance systems, and that is being done, and that's very much a joint work between the corporate performance team and the service. There's also work that's being done in terms of the use of data, so that we really understand what is happening across the wide range of services, that we understand what's happening and why it is happening. And a key element within that is understanding both our absolute performance and our relative performance. So, for example, I can say that we currently have 41.9% of the people who are accessing formal care services receive a direct payment, and that number is pretty similar to what it has been for some time. That doesn't tell you very much until I note that the national average is 26%. So we have a performance that has something like half as many people again, in fact slightly more than half as many people again, taking a direct payment compared to the national average. And that, putting it in that broader context, is causing us to look at that data and saying, right, what is it about Lincolnshire? Why are we performing differently from the position elsewhere? Is that a good thing, or is that not a good thing? But it's getting us to ask the questions, why. And I am particularly interested in comparing us with our statistical neighbours, so not just with the other 9 authorities within the East Midlands, because I think that members of this committee would have little doubt that comparing our performance with, for example, that in Derby or Nottingham is probably not terribly informative, whereas comparing our performance with other authorities across the country which are similar to us is much more likely to give us a sense of how we're performing. So we're very much looking at that. So if you look at that, what comes out is that Lincolnshire has a much lower proportion of the total population in the formal care system than you would expect us to have if you looked at our statistical neighbours. And the question as to, well, why is that the case? Well, partly we think it's an indication of the success of the preventative measures, such as the integrated lifestyle service that we've been talking about. I think it probably also says something about the community resilience within Lincolnshire, the nature of our communities. But we are a clear outlier. Far fewer people, proportionately, of our population access formal care services that you expect. We also have some of the lowest fee rates in the country. Now, that is obviously in many ways very good news for Lincolnshire County Council, because we are paying less money. But then what impact does that have on the economy of Lincolnshire? Because there are 21,000 people who work in the adult social care sector, not employed by the County Council, people working for providers. If we're paying some of the lowest fee rates in the country, then that will have an inevitable impact on the wages that those people are paid. Does that have an impact on the economic experience of the county? So trying to look at things in that perspective. We do have, if you look at the people who are in the care system, we have a higher proportion than you would expect in residential care compared to being in the community. Again, when we're looking at why, we think it may be because we are supporting a smaller proportion overall, we're essentially supporting the people who are at the higher end of need, and therefore you would expect us to be having more people in residential care. So it's always all the time asking these asking these questions. What we seem to have is a much more effective re-ablement service than most of our peer authorities do, and we have a much higher rate of doing annual reviews of people's cases, and we have much shorter waiting times than most of our comparative authorities with that. So those are a range of bits of evidence that suggest, not just in terms of our targets, but if you compare us to other similar authorities, we are probably delivering better services than most of our statistical neighbours, and we seem to be doing it at a lower cost than most of our statistical neighbours. So that gives you a better sense. We are also starting to use the data more effectively to look at what's going to happen in the future and telling us about our population. So one piece of information which has emerged just very recently from the analysis is we've been looking at the average age at which older people enter residential care. Because one of the key points that is relevant is that if people enter residential care too early, then apart from the fact that residential care is expensive and there's, they may well be spending money and often their own money less effectively, but also people are losing independence, losing quality of life by being in a residential home rather than if they could stay in their own home. What we're finding is that on average now people are entering residential care at the age of 84, and that puts a very different picture on things, because actually that suggests that people are not entering residential care too early, because we used to talk about the old elderly as people who were over the age of 75. Well, we're now we're dealing primarily with people over the age of 84. But what we are seeing is that instead of people staying in a care home for about 2 years, they're staying for 3 or 4 years. And that is one of the major factors. So understanding that, why have we got a larger proportion of the population in residential care? Because they're living longer. And on the one hand, we can go, okay, that's a significant cost pressure for the council. But it's a real success story that people are living longer and they're having a better quality of life. But it does mean that there are consequences for us. So we are doing a great deal of work, and I think what I've been trying to do is to put the performance data in context for you. So we're doing a great deal of work to try to ensure that we have a really effective person-centred, strengths-based approach, which has a real focus on prevention, on early intervention, on appropriate assessment, on the delivery of good care in the system, and all the time trying to secure the very best value for money, and that we're using the data not just to say, well, are we hitting the standard, are we ticking the box in terms of the performance target? We're trying to understand, if we go down a level and understand the different cohorts of people across the population, what's the experience of different groups of people? Do people who have a mental health issue, do they have a different experience from older people? Do people who have learning disability have a different experience? To try to really understand what's going on so that we can ensure that the services that we are offering are built around the needs of people rather than people having to bend to meet our needs. As we develop our understanding more fully, that will also allow us, I think, to start to understand more on a geographical basis. So at the moment, we've been focusing in terms of client groups, different groups of people, in terms of, in effect, their clinical assessment. We will, in due course, be able to say, well, do the people of East Lindsey have a different experience from the people of South Holland? Do people in rural areas have a different experience from people in urban areas? And that, again, will be absolutely critical in us not just hitting the targets, but making sure that we really are achieving what we need to for the people of Lincolnshire. And that's what I'm trying to do, to use the performance data to drive what we do, rather than it simply be a sort of, well, are we doing okay? So hopefully that gives a context for the committee.
Yes, no, that's very good. And I mean, if you take like those supported to live, well, take direct payments at 40.9 or whatever % it is, I mean, in reality, there is a percentage there that will never be able to just operate to direct payments just because of their situations. So there is always a limit on something like that. And I suppose in some sense, looking at it from a slightly different angle, it is about, yeah, we are punching well above the national average.
Can I just come back on that, the point about direct payments? So, strictly speaking, no, there isn't a limit, because indeed, I mean, you're absolutely right, there are many people who would not themselves be able to manage direct payment,
Yeah.
but there might be someone, you know, a member of their family, a member of their community who could potentially do that. So in theory, it would be possible for everyone to have a direct payment, but I think the question much more is, who are the people for whom it is a benefit? And it's just one of those issues that, seeing that we are very different from the national position, we need to understand, is that a good thing? It may well be, but understand that position. It's the comparative data, I think, that is critical for us developing that deeper sense of self-awareness.
Yeah, and then the flip side is, if you don't watch it, you get social isolation if they don't mix within the community when they're back at home. Right, Mark, then Trevor.
Yeah, thanks, Chairman. Thanks, Martin, for not only for the report, but I think for the explanation you've just given, which I found really, really interesting. Especially the point you were making about, you know, in terms of who are we going to compare ourselves with? Well, yes, it's probably best if we compare ourselves, you know, with the Norfolks and Gloucestershire's and the lot of this world, rather than comparing ourselves with our East Midlands neighbours. I mean, during my working career, I was an officer, accountant in local government for about 10 years. And I worked in diverse authorities, Nottingham City Council, Rutland County Council, where you couldn't get two more different councils than those two, and also East Staffordshire District Council. I mean, interestingly, I was the head of finance at Rutland County Council, in charge of adult social care finance. But I mean, and in terms of the people we had in residential care, it was 120, and we can name them individually. And I've seen Pam's clips and spreadsheets and the model she went through with me, which is a fantastic model. So I agree completely with you that it's important that we find similar authorities to compare ourselves against. But I was really pleased with the explanation you were given about the data, because it seems to me that the approach you're taking is, we've got the data, we are consistently now achieving our targets, which is fantastic. Potentially at some point, I guess, you know, with all targets, at some point they could be assessed to see if need be altered. But I think that's for another time. But I was really pleased to see you working with the services to give value now from the data that we've actually got, which I really think is important. I made a few notes down here. In terms of our rates, I think maybe, and the consistency of rates, I think that's probably down a great deal to having Lincoln in place and the work that we do with Lincoln, which I think is really good. What comes out of this is that all of the early intervention stuff that we know we do, and which we just spoke about in the previous item, are having an effect and impact. Because for me, I think it is crucial to try to keep people at home for as long as possible, independent and within the within the community. So, and we know that's better for us as the council, and it's better for the people as well. I'm not asking specific questions. I'm just really pleased with what I've been hearing, actually. And in terms of cost, because this is interesting, because I've been recently at the LGA conference. I've been at the County Council Network conference. I go to the CIFA Finance conference, and we talk about funding, and we talk about the extra costs the rural councils incur because of sparsity and rurality in terms of providing services in a big geographical area like Lincoln when compared to providing them in a city or more urban environment. But I'm kind of getting from what you said, whilst potentially that is a factor for us, it's probably not as major a factor as perhaps some. If you just provide me a little bit of context around that, because I want to be able to sort of go and say to the government, we need more money because of sparsity and rurality. But then you just said that potentially our costs may be a bit lower, and I'm just trying to understand that potentially if that sparsity or rurality we didn't have, our costs potentially, from what you're saying, could be even lower. So just something around that which I think would be really useful to inform the conversation that this council will be having with national government around fairer funding. Thank you.
I was going to say, you're campaigning for the fairer funding campaign. So, but yeah, it was very interesting actually that last Friday Martin Hill was on about it, and actually if we got the average fairer funding, I think it would be about 100 million, 120 better off. I mean, it's quite astounding really, but right, anything to say on that, Martin?
Right, there were a number of points that you made, so I'll try to respond to several, and then I will particularly pick up the rurality and sparsity issue. So in terms of the fee rates and the relationship with Lincoln, the Lincolnshire Care Association, I think that Lincolnshire is a really, really good example of the positive benefit that can come to all parties from there being a really good relationship between the council and the provider association. Now, clearly there is always a risk that that kind of relationship can become a bit cosy. I think we're clearly not in that position in Lincolnshire. I have, previously in my career, I worked for a council which had a very hostile relationship between the local care association and the council. And I have to say that my experience as an officer in that council was that did not hold fee rates down. That in fact, because of the tension that existed between the council and providers essentially saw their interest as being served by working out ways that they could ratchet up fee rates as high as they possibly could, and it wasn't really their problem of what happened to the council. In Lincolnshire, because of the very good relationship, which has taken a lot of effort, I have to say a lot of effort on both sides, but I think very well directed effort on both sides, there is that understanding that and that mutual confidence, that recognition that the county council can't screw fee rates below a reasonable level, because these are businesses that do actually have to make money. There are costs, they do have to make money. But equally a recognition from providers that the council is operating in a constrained financial position. And with that mutual understanding of the context, it means that actually you have a much more pragmatic and realistic conversation about fee rates. And I think that one of the things that also comes from that is because there is that mutual confidence, it means that providers may not necessarily press for the highest possible fee increase this year, because they know that that might then lead to a lower fee increase the year after, and actually it's better for it to be a bit more even. So I think there's a great deal to be said for the very positive work that has been done on both sides to develop and maintain that relationship, and it is striking how different that is from some other places, and I think lots of positives. In terms of the impact of prevention, I think one of Lincolnshire's real strengths is that the County Council has continued to invest in prevention, and I think that not only does that deliver real benefit for Lincolnshire people, it delivers real benefit for the bottom line of Lincolnshire County Council. I previously worked for a council which some years ago had been in financial difficulties and had essentially cut all of its preventative spend, saying, well, we're legally required to do the residential and home care work. We're not legally required to do the other, therefore we're going to stop that. That council then had the highest rate of growth of demand for formal statutory adult social care services of any council in the entire country, which had a significant negative financial impact on the council, and of course was not good for the people of that council. So I think the continued investment and confidence in preventative activity by this council is very much is very wise and is very positive for a wide range of reasons. So picking up then the issue about rurality and sparsity, it works in a number of different ways, and it's always a little bit of a balance. So in a rural and very large county like Lincolnshire is, that can work in favour of holding fee rates down because people can't go elsewhere. So I've worked in authorities where it was really difficult to hold on to staff because within a reasonable commute there were 6 or 7 other places that they could work. Lincolnshire is a rather large place, and therefore it can be that people simply, it's harder for them to go elsewhere, and they are therefore to an extent by geography forced to remain within the Lincolnshire system. And because the Lincolnshire economy generally has lower wages than other parts of the country, that means that there's less of a difference between what we can what providers that we pay for can offer and what other parts of the economy can offer. So that can help hold wages down, which isn't good for people, but it helps the bottom line. On the other hand, we do find that as you'll be well aware, the younger population tends to live in the urban areas of the county. The older population tends to live in the more rural areas, and therefore getting people, in terms of getting a workforce, is a real challenge. And one of the particular factors then is the amount of time that people have to travel. So we do have to build in more travel time, which is therefore more cost. So that pushes in the other way. To an extent, the way that we've been dealing with this in the last couple of years has been through quite significant international recruitment. So Lincolnshire stands out compared to some of the other parts of the region in the number of international recruits that we've taken to do care work. So I've met a number of those workers. Their commitment and their passion for delivering care is extraordinary, and their sort of positive spirit of having come to this country and been welcomed and accepted in Lincolnshire and being able to deliver really high quality care is really palpable. But clearly that's not a long-term sustainable model, and it does mean that our care workforce now in many ways looks quite different from the local population. But that does allow us to keep attracting staff at the wages that providers can afford to pay based on the fee rates that the council can afford to provide. And because again they're then in a rural county, it's easier for us to hang on to them so that they don't go elsewhere. So I think rurality has really quite significant challenges. We're dealing with them, but essentially we deal with them by bringing in people who are prepared to work for less than others might be prepared to work for, and by having staff who are unable to go elsewhere where they might be able to get better jobs. So as the economic development programme from the council and indeed the mayoral combined authority, as that kicks in and there are more better paid jobs available, realistically one of the consequences will be that we will struggle to maintain the workforce that we need for social care unless we have more international recruitment. And I don't think that's a long-term sustainable model. Sorry, that's a rather longer answer than perhaps you're expecting.
As long as it's quick.
It's related to what I just said, because my wife spent the last 15, when she's still working, it's 15 years as a care worker. And the last company she worked for an awful lot of their care workers were actually in their 60s and 70s. They'd actually retired as care workers, were drawing their state pension and were still working because they enjoyed it. That was one particular company. Is it something, is that typical of Lincolnshire? Is it an older workforce that we have, plus people who have retired and are actually using it to supplement their state pensions? Thank you.
So for a long time, the average care worker has been a woman in her mid to late 40s who is the second earner in her family. And that's a very typical position both in Lincolnshire and nationally. There are comparatively, I mean, the perception often used to be that these were young women in their late teens or early 20s. Of course, there are some, but actually that's not typical of the workforce at all. It is very much often a career for people who are returners from having brought up children, an older population. We therefore do tend to get a lot of people retiring, but they do it because they love it. And I mean, it is one of the things that if you meet care workers, I mean, they are an incredible group of people. Clearly, they need the money, but all of us need to work to live. But so many of them, it is so clear that they do it because they love working with people. They love the impact, the positive impact on people's lives. And so it's not at all surprising that people are retiring but then coming back because it is a wonderful way to work with people and connect with people. But it's a tricky workforce to rely on because, of course, as we all get a bit older, care work is not easy work. It's physically demanding work, and as we get older, that becomes more difficult. So we have a lot of challenges in persuading people that care work is a good career, that it can be a career rather than just a job. But it's a lot of challenges there. But some amazing people, and I can't praise the people who deliver care highly enough.
Yeah, I mean, there's one thing, when you go to the care awards, you just see exactly that, the enjoyment and the satisfaction and the everything on their faces. But in fact, really, ought to try and figure out a way how we could sort of perhaps over a term actually sort of invite maybe a couple from each year from this committee to go forward to actually see the care awards, because it is, really quite inspiring actually. So, right, I've got Trevor and then Mike. If we can keep them a bit shorter.
I will do, Chairman.
Both questions and the replies will be good.
Just to say, Chairman, I think in terms of the paper, it demonstrates in terms of how effective and good quality services we provide around social care. I think we've come on leaps and bounds in terms of the last 20 years. And this paper actually demonstrates in terms of the quality of services and how lucky people in terms of Lincolnshire are in terms of the quality of services we've got. We've got a really effective assessment process and review process. It demonstrates that we do that in a very timely manner. It's really pleasing, I think it's already been said about direct payments, in terms of the number of people on direct payments. It's excellent in terms of giving people more autonomy and choice in terms of how their services, their needs are going to be met. And I think it's all credit in terms of the workforce we've got in terms of delivering that. It's very outcome focused, so in terms of the service delivery, I think it's pleasing that clearly it demonstrates that we're really focused around delivering outcomes for our customers in a very positive way. It's pleasing, I think, in terms of the low numbers of people in terms of residential care. We only place people in residential care at the last resort. I think we demonstrate that we do everything in terms of trying to actually keep people in their own accommodation for as long as we possibly can. The worry in terms of the paper is around fuel poverty for me. The high number of people in fuel poverty. I'd be keen to understand in terms of how we're working to address that. And that's become even harder, hasn't it, recently in the last few months around the withdrawal of the fuel allowance for a lot of people. And the impact, what that will have, I think there's some data come out only today in terms of the impact of withdrawing that fuel allowance, how it will impact on people, and more importantly, those who live in Lincolnshire, in very rural areas. And then just a quick query. Whilst we do an excellent job around prevention, my frustration constantly at district level is around DFGs. I just wonder where and how we can have some discussion. It might not be this morning, but at some time, maybe outside the committee, of the length of time it takes to get DFGs delivered. In my particular area, in West Lindsey, it might be different in other areas, but we've got huge issues in terms of delivering around the finance, around DFGs, but I'm constantly really concerned in terms of the length of time. It's taking months to get DFGs delivered. And I think we're missing the trick in terms of that preventative element of keeping people in their own homes by providing 1, 2 simple adaptations, or getting those adaptations in place to provide early discharge. And it's taking months and months and months, and we seem to have the same old discussion year in, year out, but it's taking months. And I just wondered whether there's an opportunity to have that discussion in terms of how can we actually improve on that element. It might, like I said, it might not be the same for some other areas of the county, but it certainly is in West Lindsey.
I think, I know there's been quite a lot of reform over DFGs over the last couple of years. My view originally, when I sort of saw DFGs and how they operated, there was some good with it and there was some bad with it. And in effect, the good was that when you went in and you say put a wet room in, great, or even a stellar stair lift or whatever. But the bad news was when the person was only in there 1 year and then the next person came in and basically ripped it all out. And it was sort of, making in effect good use of money long term. And I know it's all been revamped, but I think for your case, it's perhaps best to have a word outside with Martin and just see where it is specifically to West Lindsey. But I know it's sort of, that they changed the way it's sort of the initial funding was and how it's rolled out. So I think it's still being fine-tuned anyway, isn't it?
So very, very happy to have a conversation about DFGs. I mean, nationally, government has repeatedly put more money into DFGs, and obviously that funding, although it comes through the county council, is passported to the districts. Very happy to have a conversation about the process and how that's all working together. On the fuel poverty issue, I would absolutely agree. Fuel poverty is a really significant issue, and that it can have a really major impact both on people's quality of life and on the likelihood of them accessing care services. A council I worked with a few years ago did some work where they identified that people over the age of 75 who were living on their own in poorly insulated houses were very, very much more likely to end up in hospital within the next year compared to people in a different situation, and that was very much a fuel issue. And so there is work that we can do. I mean, we're working with as the paper says, we're working with the Lincolnshire Financial Inclusion Partnership to try to address that, because clearly that's not a care issue, but there are really significant issues in terms of if people can avoid fuel poverty, the positive impact that has on their lives and therefore their demand on other services is really considerable.
Excellent, thank you. Mike, do you want to come in?
Thank you, Chairman. Going back to admissions to care homes, I know we're doing our best on that, but thinking forward, you've got the data as to how the growing old population will be. Have we had any thoughts yet on how we're going to deal with that probably extra demand, but on the present figures we wouldn't be able to meet the financial implications?
So I'll briefly talk about the older people side, and then I'll actually ask Justin to come in and talk a little bit about accommodation for working age adults with care needs, because we've been doing some work there. But we've been doing work, the point you make is absolutely right, that we know that the Lincolnshire has an older than average population, and it is getting older faster than the rest of the country. So the last Director of Public Health's annual report was bringing that position out very clearly about the number of people over the age of 85 doubling within the next 20 years or so, and on the basis that something like 90% of people who are over the age of 85 are in the care system somehow, whether they're at home or in residential care. Clearly that will have an impact on us. So we are starting to do some work, a needs analysis of trying to say, rather than just looking backwards and saying, well, we've seen these trends in demand over the last several years, looking forwards and saying, well, everyone who is going to be over the age of 85 in 5 years' time, well, they're already over the age of 80 now, and we know where they are, we know who they are, so we can do some fairly accurate modelling. So we're looking to do that needs assessment to estimate, well, how many, if we carry on as we are now, how many people are likely to need to be in different forms of care, not just residential care, but that's obviously a key one, so that we can get a sense of if we carry on as we are, and then thinking, well, what might it be possible to do to reduce that number? Because being in residential care is never a desirable outcome. You know, it may well be the best thing for an individual at that point in time, and people can have a really good quality of life in a care home, but it's never where you would want them to go if there was an alternative. And so we'll be looking at, well, what is it that we could do? And so a particular issue is looking at supported accommodation, extra care, and the like. So we've done an initial piece of needs analysis there, and that's suggesting that we have dramatically less extra care and supported accommodation for older people in this county than you would expect us to have using national benchmarks. And so that's getting us to think, well, actually, there are probably 400 or 500 people who are in residential care who probably it would have been better for them if they had been able to go into extra care or some other form of supported housing. We need to work out on the map where they are, because you know, we don't want to be in a position where people have to move from one end of the county to the other. That's not good for people's quality of life. But it's giving us that sense of this. There is a need here that we can now work out how to address, and therefore, rather than us needing that number of care home beds in 10 years' time, it might be several hundred fewer. So we're trying to do that analysis and work out the way forward. So if I ask Justin to come in, because we've been doing similar sorts of work in terms of working age adults, particularly working age adults with learning disability, and that's been coming out with some quite interesting findings from that. But Justin, do you want to talk a bit about that?
Yeah, thanks, Martin. So, yeah, we've been doing some joint work with an organisation called Empower. Empower are basically piloting a tool that they've previously used in special educational needs in children's services, but wanting to use it in an adult social care environment. So we've adapted that tool, which we call the Better Lives tool, for Lincolnshire, and been piloting it with our learning disability population. And what that does is that it's an assessment tool effectively, and it looks at people's needs, and then it also allows you to aggregate that need and also look at it in sort of scattergram form, etc. And it allows you to make judgments really on comparing levels of need to the price that you're actually paying for that care as well. And what the other part of it is, it links to practitioners, and the practitioners' feedback in terms of actually, is the person living in the most independent setting that they could do, and actually could the person live in a more independent setting if the if there was suitable accommodation and care available as well. So again, all of this information is being collected and collated and helping us to inform our commissioning strategies. And ultimately, coming back to Martin's point, is, you know, how much community supported living accommodation do we actually need in Lincolnshire? We obviously don't want to commission too much because it would sit there empty and potentially pay voids. But if we don't have enough, we might then, people might be inappropriately having to go into residential care because there isn't alternative care available. So we're getting very close to actually getting the trajectory information to say this is how many units of accommodation we believe we need, and that will inform and add pace to the work we're doing around our capital programme, but also look at other commissioning opportunities. So currently we do still commission community accommodation, but it tends to be on a case-by-case basis. Whereas if we're able to aggregate that and communicate it to the market, then we could get different people in to actually help and make a step change in that, really, and reduce our reliance on residential care for people with learning disabilities. But that programme of working we can also then take to other cohorts as well. So we're starting to look at that with our mental health population as well. And tentatively we're also looking at the older people's population as well. So yeah, a really helpful piece of work that's going to help to sort of fast track our commissioning opportunities and optimise the balance of care in Lincolnshire.
Thank you for that information. Obviously, I know what it takes, the planning and preparation for some of these buildings. You know, it could be a 5-year process. So are we that far forward thinking for some of our sheltered or supported accommodation going forward? Thank you.
So we have a number of schemes that are in development now. There is, for example, Diamond Place in Welton, which is we've been doing in cooperation with Lace Housing. That's due to open early next year. We've been working with North Kesteven for a scheme in Sleaford. That's in sort of planning stage. So there are some schemes in the pipeline. I think what the work that we've been doing recently has been saying, actually that pipeline needs to have a lot more in it. So we are bringing more schemes into play, but the pace at which we've been doing that. So we need to see whether we can bring them a bit sooner, and we need to see if we can have rather more of them. And I think that's been the key thing. So it's not as if that there hasn't been any development, but we need to be more of it and faster.
Yeah, thanks for that. I'm aware of the 2 schemes that you mentioned. Even forward thinking beyond that, once there's a dip in demand, would the accommodation then be suitable for somebody else to occupy?
So there's a couple of things that can be done. So for example, there's another council in the region which has been able to ease off the demand for residential care, and there have been a couple of care homes in that authority that have closed because they're no longer required, and the authority is now looking to convert those care homes into extra care housing. Now it's not entirely straightforward because of course extra care housing is a different form of care from a residential care home, but it does mean that extra care and other supported housing doesn't necessarily have to be a new build or a major reconstruction of an existing building. There are things that can be done to refurbish relatively quickly an existing building, and therefore there are possibilities that we might be able to bring things on stream sooner. Part of what we need to be able to do there is to have done the needs analysis so that we can have that sense of, well, how much residential care do we need, and therefore have the conversation with the current providers to say, well, we haven't done the work. I don't know the numbers yet. So I'm hypothesising here. I don't want to set any hairs running. But were, for example, we to say, well, we've got this amount of capacity at the moment. There are 200 or 300 beds that we're not going to need in the future. We could then start having conversations with providers to say, well, we think your home might be one that would be suitable for conversion from being a residential care home into being an extra care facility? Can we have the conversation with you so that rather than you just not being able to get the people and therefore going bust as a business, we can have a planned and managed process where you transition from being one type of care to another kind of care. So it allows us to have a managed and engaged process with the market. So that's where we're seeking to get to.
Thank you very much. Very pleased to hear that we're that forward thinking.
Yeah, thank you very much. I think we've covered that well, and congratulations on the performance, actually. I think credit due. So, well, thank you both very much for that. So that then takes us on to the works programme.
Thank you, Chairman. Just drawing the committee's attention to pages 118 and 119 of the agenda pack for the two, where the items are listed for the two remaining meetings in the current County Council term. So there are 4 items on each agenda and there are no changes to report. Thank you.
Excellent, thank you. I think, yeah, it all looks well and good on those forward items, so brilliant. Okay, well, thank you all for coming, and have a good rest of the day. Thank you.